All right, we are live for our third part in our series and final part of our infantile spasms Q&A this week. Again, I'm Betsy Pelan, president of Hope for HIE, and I'm joined again. And we're live again. Sorry for the interruption. We lost connection there. We were saying we were doing so well with technology during this series. So Hannah, if you want to pick up on risk factors again.
Sure, yeah. So I was talking about risk factors for infantile spasms from our recent study. And so what we'll talk about now, the children at the highest risk factor, if they have all three of these factors that we found. So either a severely abnormal EEG background or seizures recorded on 3 or more days. That's one risk factor. The second is abnormalities on the picture of the brain on the MRI in specific locations called the brainstem or the basal ganglion thalamus. And then the third risk factor is having an abnormal examination at the time of discharge. And something that doctors will look at is something called the baby's tone at the time of discharge of examination. So what we found in our data is that if children had all three of these risk factors, the risk of infantile spasms was a little more than 50%. So this is a group that everyone wants to be careful with and aware of. So certainly a child with all three of these risk factors, the parents should be educated. The child should have a follow-up, most likely with a neurologist, or if anything, with an effective provider. And we talked yesterday about an effective provider for infantile spasms is one that knows about what are infantile spasms, a provider that will be willing to look at a video that you've taken of these events you're worried about, and a provider that will know how to get the testing that's appropriate. That's an EEG test of the baby, and will know how to initiate treatment. So for a family who has those three risk factors for the child, having all that in place and some follow-up planned would be advisable. On the other hand, if a child has no risk factors, then it can be a nice piece of information for families that they'll be unlikely to have infantile spasms in the child. And as I mentioned yesterday, most children with HIE do not develop infantile spasms. Interestingly, the children with just one or two risk factors fell somewhere in the middle with a risk at about 5%, which is the baseline risk that we saw in our study overall. I'll pause there and give the others a chance to talk.
All right. Thank you so much. And Hannah, how many kids are enrolled in that study?
Yeah, so that's a little over 200 participants, and about half of those babies had HIE as the cause of their seizures.
Okay, very good to know. Thank you for sharing that. So the next question up, I believe, is for Adam, and I'm scrolling through because somehow this got a little crazy.
Oh, well, before we get to the next question, I think we'll ask. So Hannah did really focused on the who, right? So which of those risk factors are the most likely to cause infantile spasms? And the other part of research that's actively happening right now is why, right? So we know the groups that are at highest risk. How about now the why question? And so that's an area that's being investigated by a couple of different groups. One thing that we're doing, Dr. Glass and myself, we're looking at different genetic markers in babies with HIE to try to figure out whether or not there's different genetic markers that might also help ascertain risk and also get at some of the mechanisms that might predispose children to infantile spasms. Other studies are looking at a more global population, so any baby, not just those with HIE. Some of those studies are looking at learning healthcare databases. So, we know kids with HIE are at increased risk, especially with the risk factors that Dr. Glass was talking about. Some other research is trying to target other groups in the medical system, trying to pick out different diagnoses and different alerts that might cue providers into who might be at highest risk. And again, when we do that, we can take different routes to try to understand that why question. One thing that groups are doing is looking at EEGs in a little bit of a different way. So looking at connectivity patterns to understand the why. Other groups are looking at blood markers. And again, we're looking at different genetic markers. One larger initiative that's occurring is in children with a diagnosis of tuberous sclerosis complex, or TSC. So different than HIE, but we know infants diagnosed with this particular disorder, about half of them will go on to develop infantile spasms. And so there's a large study out of Europe and now in the United States looking at different EEG markers and blood markers to understand the why aspect of this.
All right. So there's a question that just came in, and I know that we have worked with you guys on looking at different statistics because everyone is always interested in percentages. Lisa's asking, I read that 75% of neonates with birth asphyxia end up with infantile spasms. Is that true?
That's a really good question. I've not seen that statistic, so I can't comment on that specific statistic or study. The studies that I've read and quote are anywhere from 5% to about 30%. Again, in our data set, and this is a very modern era data set from 9 centers across the United States, the risk was about 5%. And this was only the children that had seizures in the neonatal period. So a lot of kids with HIE don't have seizures. Mm-hmm. There is some thought that hypothermia might be helping reduce the risk of infantile spasms, but the data are very limited on that so far. But in my personal experience and in any of the literature I've seen, the 75% rate would be very high. I'd love to see that reference to understand, what type of cohort they studied. Were there any specific inclusion criteria, for example, any reason why this might be a much more severe group of children that were studied?
Very helpful. Thank you. So moving into the next question, what is the best initial treatment for infantile spasms?
Yeah, so yesterday we were talking about the different types of initial treatments, whether that be hormonal treatment with prednisolone, the neuropeptide ACTH, or vigabatrin, or combinations of those, right? So we talked a little bit about the research that was published a couple of years ago called the ICIS study, ICISS, that took place in Europe, which compared hormonal therapy with or without vigabatrin, showing that the combination had a little bit more success, though with increased side effects. Right now, there's a trial in the United States that should be enrolling shortly. University of Colorado is the main site, but there's several sites throughout the United States that are going to be participating. And that's going to be comparing vigabatrin alone versus a synthetic form of ACTH versus the combination of the two. And so this will be a randomized trial looking at that in a little bit more detail, comparing those different treatments. It will involve a few hundred children, so it will be a larger study, one of the larger ones to date within infantile spasms. Ideally, though, we'll get that information that will help us say, okay, this is better than this, but that's really at the group level, right? And when you're thinking about your own child, you really want to know, is this going to be right for my own child? And so that's research that is also occurring in parallel, where we're trying to figure out, okay, well, maybe there are some kids who need both therapies, others who only need one, and others for whom these initial therapies won't work at all. Like we were talking about yesterday, one of the paradigms or approaches we use is, trying to figure out which is going to work quickly. That's right. We start something, we check back again 2 weeks later. If it works, fantastic. If it doesn't, change, check again 2 weeks later, right? So in one way, we're trying to use different markers at the time of diagnosis to help figure out whether someone might be a responder to hormonal therapy, vigabatrin, or a combination thereof. Our group specifically is looking at blood markers. We're looking at the role of inflammation and how that might explain responders versus non-responders, right? We know that steroids impact inflammation in the brain. And so what we're looking at are blood markers of these inflammatory molecules to help understand their role in why someone may respond or not respond. Other groups are looking at EEGs, so going beyond what I might just look at when I'm reading an EEG, but actually using computer systems to look at very fine details that the human eye can't pick up to understand whether or not someone might be a responder or non-responder. And so hopefully, once we kind of get all this information together, we'll not only know what are the best treatments for a group, but what are the best treatments for any particular person. So we can, again, move through these treatments quickly and hopefully modify or prevent any negative neurodevelopmental sequelae from occurring.
Very helpful. Thank you. Is there a way to predict who will respond to initial therapies for infantile spasms?
Yeah, and that's what we were kind of getting to a little bit. Not right now. And again, that's what our research is focusing on. So right now we're focusing on these other molecules, these inflammatory molecules called cytokines or chemokines. And we're also looking at the EEG, using quantitative EEG measures to understand the different connectivity of the brain, because we know that is changed with infantile spasms. And hopefully a combination of these things will give us risk scores. So we can really say, okay, in this patient, they're going to respond to X, Y, or Z. And this patient will respond to this X, Y, or Z. We're getting there.
It's great to hear. And what is the best treatment if hormonal therapy or vigabatrin do not work?
Yeah, great question, right? So we know a little over 50% of people will have a long-term response to hormonal therapy with or without vigabatrin when you look at kids 3 months later or 12 months later. When those medications don't work, we know less about the best steps forward. There's been a lot of research into the ketogenic diet and how that may play a role in the treatment of infantile spasms. Here in San Francisco, that's one of the treatments we like to use if someone does not respond to hormonal therapy with or without vigabatrin. There are clinical trials that are starting or in process. One is looking at the role of cannabidiol or Epidiolex in the treatment of infantile spasms. And there's a couple of studies in the preclinical pipeline looking at novel ways to target different receptors in the brain. So new anti-epileptic drugs and how they might play a role in treating infantile spasms. So there's some research going on right now and some more in the pipeline that hopefully will help us understand these next treatments. The other role that the inflammatory research our group is doing, we're hoping we may be able to identify pathways that might be able to target specific changes in the brains of people with infantile spasms. So akin to how some molecules or drugs are used to treat rheumatoid arthritis, we may be able to show that those same inflammatory pathways are changed. And so there may be an opportunity to use drugs that target those inflammatory pathways specifically in the treatment of infantile spasms. So moving beyond steroids, but going a little bit more specific and targeting particular pathways.
Very, very interesting. Is there anything that you want to say more about current research being done before we take questions from our audience? Because we have a couple of those popping in.
Yeah, I think infantile spasms has traditionally it hasn't been as well researched, right? It's a relatively uncommon disease, and pediatrics in general gets a little bit less funding than some of the adult diseases like Alzheimer's or Parkinson's disease. Not that any is less or more severe or important than another, but it just means, I think, patients and their families, the more advocating they do to different research foundations, the government, helps us raise awareness and the importance of doing research within these particular fields. So it's something we are actively doing. And I know the more people who speak up, the more we can get foundations to be aware of it, the NIH to be aware of it, so that they can really help us target and answer some of the questions we've been talking about over the last 3 sessions.
Very helpful. Thank you so much for that information. There's a couple of questions that are coming in. So one is, if a child has had infantile spasms, what should we expect next, short-term and long-term? And that's kind of, I would think, a little bit of a crystal ball question because so many,
Yeah. So if someone doesn't respond to initial therapies with hormonal therapies and vigabatrin, again, the next steps are not as clear cut, but there's other drugs we talked about in the first session. So Depakote or valproic acid, topiramate, zonisamide, those are some treatments. The ketogenic diet is one that I particularly like, but again, you have to have a center that's able to do that with a specialized dietitian. There's still a very good chance that you can get seizures under control with these different combinations of therapies or different trials of these therapies. But we know that after the first two medications, the chances that someone being seizure-free decreases. And each trial of a medication where someone isn't responding decreases that further and further. We talked a little bit yesterday about the corpus callosotomy procedure. It's a surgical procedure that disconnects the two parts of the brain. And a recent study that came out of Japan that in a group of about 50 infants, children who had a history of infantile spasms, 50% who had spasms ongoing alone responded 100%, had complete resolution of their spasms after that. So, keep hope, because there are other things that can be done, other medications to try, different trials that you can potentially enroll in shortly, and different surgical procedures that might help. If someone isn't a resective surgical candidate where there's a part of the brain that may be developed differently that you could take out.
Yeah, and I'll add to that, because we know that the children with the most severe brain injury are the ones at risk for spasms. These are children that will benefit from a range of therapies for intervention. So early intervention, physical therapy, occupational therapy, speech and language therapy. Getting the seizures under control is certainly the most important thing, but these children should also be enrolled in a local 0 to 3 program. We know that an enriched environment, intensive therapies give the child the best chance at progressing in their developmental milestones. So we really encourage that. And especially if the neurologist, for example, maybe only has time to deal with the epilepsy itself, making sure the pediatrician is an advocate or the family themselves are advocates for the child, getting the therapies that the child will benefit from.
Really great. Obviously, early intervention, we know we have seen that in our community. The enrollment is such a high rate because it's that has been so great across the country to make sure that's right out of the NICU or PICU, depending on their circumstances. So very grateful that we have those programs in the US for sure. There's another question that popped in that said, is it possible to have IS but have a normal EEG? What would be your next step if a child presents this way?
Yeah, it's possible, but pretty uncommon. So, right, because if you have spasms, you're having seizures, and so your EEG isn't going to be normal because of those seizures. But we talked a little bit yesterday that not everyone with infantile spasms may have the full pattern of hypsarrhythmia on their EEG, especially if people are identified earlier and earlier. And so we still treat kids with infantile spasms with the same initial therapies, right? We're not going to wait for someone to develop hypsarrhythmia. We're looking to really get these under control before, again, sort of the cliff falls.
Yeah, and I'll add to that, if a parent's worried that these are infantile spasms, but the EEG is truly normal, especially if the events are captured, then you have to think about something else. Maybe there are different types of events that are not seizures, or a different seizure type that's not infantile spasms. So I agree with Dr. Numis that you don't have to have hypsarrhythmia to treat spasms, but there should be some signs on the EEG that there's something abnormal with the brain going on.
That's definitely helpful, I know, for this parent in particular. So thank you for that. I have not seen any other questions come through. So I just want to take this opportunity on behalf of Hope for HIE to thank you both once again for dedicating this time with us this week, preparing for all of this. And, our community is so grateful for your contributions to this program. We do have one quick question that came in right at the buzzer.
Okay.
That I think would be a good one to ask real quick. Can spasms cause more injuries and more additional damage?
Yeah, great question. So the spasms themselves don't cause brain injury, but what occurs is something called an epileptic encephalopathy, where the pattern in between those seizures cause development to stagnate or regress. It's not actually additional brain injury, so it's not like HI is happening again or there's a new stroke or anything like that. But for reasons we still don't quite understand, it causes the brain networks to become disorganized, and that causes the developmental stagnation or regression.
That is very, very helpful. We'll reference that because I know a lot of people have that question often. So again, I want to thank everyone who has tuned in over the past 3 sessions. Great questions. And again, to our physicians and researchers who have joined us, you guys, honestly, this has been such a wonderful thing for our community. Thank you again from all of us at Hope. And we will hope to keep our communication lines open and see where we can partner in the future.
Great. Thank you, Betsy.
Thank
Thank you, Adam. This has been a lot of fun for us. So we're happy to be here.
Great. All right. Thanks. Take care, everyone.
Bye.
Take care.
All right. Bye-bye.